Good morning, everybody. I'm Kevin Fenton. I'm the Regional Public Health Director for London and the President of the Faculty of Public Health. And it gives me great pleasure to welcome you here to this London Public Health Forum. As you know, the London Public Health Forum is a forum where we bring public health practitioners or public health colleagues and those working in public health across the region together to learn together, to share and best and promising practice in public health, and where we have a chance to hear from public health leaders working at the coalface of policy development and program implementation about key public health issues in the city. For today's forum, we're going to be focusing on issues related to tackling child poverty and nutrition in the region. But many of the lessons and the issues that will be discussed today will undoubtedly be relevant to other parts of the country. We have a number of core objectives for the session today, including understanding the current state of child poverty in London and some of the challenges and mitigations, looking at some of the barriers to healthy eating and the time of rising child poverty. We're going to highlight some of the great work being done to improve the quality of food consumed by London's children and young people, and we'll spotlight some promising local practice. And finally, we'll be able to identify ways to improve baby, child, and young people's nutrition at a pan-London integrated care system and borough level. So we look at multi-level approaches to tackling child poverty and improving child nutrition. So those are the objectives for the day. We have a few housekeeping announcements, and these are highlighted in the slide, which is currently projected. As always, remember to stay on mute unless you're speaking. For the presentation period, please turn off your cameras, turn your cameras on if possible. We are always keen to see who's joining us and to create a sense of community on these calls. We look forward to you engaging as you go through the discussions today. You can add to the chat, raise your virtual hand at the appropriate time. We're going to have a far more interactive session this time around. So again, if you're keen to verbally contribute, please raise your hand and I'll come to you. Otherwise, we'll be monitoring. Will be raising your questions as well. Finally, the webinar, as are all of our London Public Health forums, the webinar will be recorded and the slides are going to be shared after the event as well. For those of you who need it, to turn on your own live captions, select the 3 dots at the top of your screen and click Turn on Live Captions, and you should be able to participate in the session using the captions as well. So to get us started, I just had a few opening comments before I introduce our first speaker. For the London Public Health Forum, we're always looking at the cutting edge and key issues facing Londoners. And I know all of you are aware of the tremendous challenges we've had with nutrition and poverty as we've navigated the pandemic, moved into the cost of living crisis. And today, the reality is that there are more than 600,000 or over a quarter of London's children living in poverty. And when you think about housing costs, the estimated number could be as high as 800,000 children in London who are living in relative poverty. Now, this is a public health crisis because the risk of living in poverty is not randomly distributed in the city. And we know that children, especially from different groups, for example, refugee, asylum seeker, gypsy traveler communities, some of our Black minority and ethnic communities are experience much higher level of disadvantage. And this disadvantage has impacts across the life course, whether it is on educational attainment, the conditions in which you're going to live, work, and develop as young adults, and their ability to reach their full potential as well. So in the conversations that we have today, we're going to be covering quite a number of these issues, but the session is going to be geared towards action. What can we do, understanding the nature and scale of the problem, and how might we tackle it differently? So we're going to begin by hearing from a couple of experts who are joining us today, and I'll introduce each of them as we go through the agenda. All of you have been sent the agenda for the session. So we'll begin by hearing from Dr. Jessica Allen, who's the Deputy Director at UCL Institute of health equity. And Jessica is going to speak to child poverty in London, the current situation, and what can be done to reduce its impact. Jessica, thank you for joining us, and over to you. We have 15 minutes.
Great. Many thanks, Kevin. I'm delighted to be here, and I'm particularly pleased that you're tackling this issue today. Clearly, child poverty rates are increasing, the damage to health, lifelong damage to health is therefore increasing. And there's so much that public health can do, and I think even beyond what's already happening, to really address child poverty, to mitigate its impacts, but also to call it out and have that very strong advocacy role. So I'm going to make a few remarks about where we are with child poverty. I hope my slides are loading and that you can see them. So I'll make a few remarks about the extent of child poverty, what we're experiencing, and the drivers of it, and what can be done to tackle them, as well as to mitigate its impacts. So this won't be a surprise to any of you, I don't think. Perhaps the difference between the various component countries in the UK may be surprising. Scotland and Northern Ireland with the lower child poverty rates, England and Wales with higher. You can see some very significant increases for England, but for all those, for Wales and Scotland and Northern Ireland has had better trajectories. Of course, this only goes up to 2019 to 20. And when we look internationally as well, we can see how poorly the UK fares in relation to rates of child poverty. I've circled in red where the UK is. All those countries, starting with Iceland with the lowest rates of child poverty, have lower rates of child poverty. Only a few have higher rates, Turkey, Romania, Israel, the US, and so on, and you can see those along the bottom. Another thing to point out is the trends here. So the blue bars are 2018. You can see 2014 is the circle here. So those countries with a circle above their 2018 rates have managed to reduce child poverty. Not so for the UK, where child poverty has increased really quite significantly since 2014 and not changed since 2008. And in London, rates of child poverty are higher than the rest of England. And although poverty is higher quite often in London than the rest of England, you can see that's particularly the case for children. So that damage in London is really quite significant and more significant than the rest of England. Driving these child poverty rates and the poor state of childhood in many parts of the UK for many children, public spending on early child education and care. Again, circled in red is the UK, very low rates compared to our GDP. Luxembourg, Iceland, Norway, they're on the left, no wonder they've got low rates of child poverty. And you can see here, actually, particularly for children 0 to 2, really very low rates of expenditure for that age group. Slightly higher for pre-primary children, but still significantly lower than the EU average, than the OECD average, and for many countries with actually lower GDP than the UK. So these are, to some extent, political choices. Child poverty, that all these countries have experienced the effects of the 2008 recession and economic crisis, austerity policies, and have responded differently. And as a result, child poverty rates are lower. So we need to keep this very firmly at the forefront of our minds, that the extent of child poverty in this country is the result of policies. So drivers of child poverty: low income, of course, wages, inadequate social protection, and the effects of taxation policies, and cultural racism and discrimination as a driver of low income. And we're doing a review now of ethnic inequalities in health and mental health in London, commissioned by the GLA, and we're seeing some really significant differences in rates of poverty related to ethnicity, which can really only be explained, you know, we have to be cautious about what we say about the data, by the effects of racism from employers in particular. Lower pay, lower rates of progression, lower access to good quality jobs, and so on. So I've included this in a driver of child poverty, that household impacts, and other forms of discrimination for those with disabilities, among women, particularly single women, and much higher rates of poverty for households with those characteristics. Expenditure, of course, we all know about the cost of living crisis, rising costs of housing, and Kevin's already mentioned the impact of high costs of housing. Apps drives up those poverty rates so much, especially in London, heating, food, transport and essential goods. And this is really an area where there are opportunities to mitigate the impacts and reduce child poverty, as well as tackling the drivers, these big drivers of low income, which can, of course, feel a bit out of the reach of many of you working in public health locally, out of the reach of local government, healthcare, and so on. But I think the point to be made is that this isn't the case. There's a lot that can be done to tackle and mitigate some of these issues. If we look at the annual real growth in median equivalent disposable household income before housing costs, between 2017 and 2022, the 5-year average here on the right-hand side, you can see the significant declines for that lower 20% in household income. And we are now seeing the real health impacts of that. We know, for example, that children's height has decreased in the UK in recent years. There are many other examples of the impacts on health, on lifelong outcomes for those children living in households with decreasing household income. And this is the result, as I've pointed out, of fiscal policies. And of course, in local authorities' capacity to do something about child poverty. This is the change in local authority spending power related to deprivation. 40% declines for the most deprived, this is in London, for the most deprived local authority. Significant declines for the wealthiest areas as well, but you can see that difference between the most deprived and the least deprived in terms of declines in local authority spending. And these have a real impact on children, we're talking about today, but obviously for all Londoners in terms of housing, environment, provision of childhood services. Universal credit, some of the rhetoric around benefit scroungers and stuff, we've seen a resurgence of this recently. Here we see that the cost of essentials, that for couples over 25 and under 25, the actual allowance is way below the cost of basic essentials. Similarly for single people age 25 and under 25. So for everybody in receipt of universal credit, it is insufficient to meet the cost of essentials. So I just think this point needs stressing over and over, and public health has a key role in this kind of advocacy. You cannot live healthily if in receipt of benefits. So the safety net is not really a safety net anymore. It's insufficient to keep people healthy, to keep people out of poverty, and its detrimental health impacts. Childcare costs extremely high, and there's much more that can be done to help mitigate those costs, to reduce those costs, to support families in work struggling with the cost of childcare, which are driving many people into poverty and affecting children and young people. Cost of food obviously has increased, and in conjunction with those decreases in the wages and in benefits, you can see the impact for families with children, a quarter experiencing food insecurity according to the Food Foundation. And I know you're talking about nutrition today. You can imagine the very significant impacts of all of this. Here are some of the health impacts, very familiar to many of you, I imagine. Gradient in dental caries, most deprived, least deprived, very clear gradient. And we could spend all day going through the data looking at these gradients in health outcomes for children. Obesity, again, familiar to many of you. This is obesity year 6 by deprivation, most deprived. And you can imagine the cumulative effect as well of all of these health outcomes that we're looking at. Adverse childhood experiences, again, much higher likelihood of experiencing adverse childhood experience by income. Most deprived, the pale green bar, and you can see for all these adverse childhood experiences, this gradient. So it's not just the poorest, although they're much more likely to experience adverse childhood experience, there's a gradient. So we need programmes to reduce their incidence, but also to tackle that gradient. And if you experience 3 or 4 of these adverse childhood experiences, really the outcomes you're likely to experience across life are significantly harmed, and the likelihood of experiencing multiple adverse childhood experiences a very, very clear gradient in that. You can see these gradients again in health outcomes following early childhood disadvantage, poor educational attainment, the steepest gradient, obesity, psychological distress, poor health, likelihood of smoking, and then again, as I mentioned,
Jessica, I'm sorry, the slides don't seem to be moving for us now. So
that's moving on my screen.
They're moving on your screen.
Yeah. You're not seeing the adverse health and educational outcomes.
No, the last slide we're seeing is the food insecurity graph from the Food Foundation.
Okay.
So shall we project for you?
Please do. I'll stop sharing.
Okay, thank you. And then we will move forward.
So, is this you sharing now?
Yes.
Sorry, I couldn't get off mute. Yes, I'm sharing them now, Jessica. So if you just let me know when you'd like me to move on, I'll just get back to where you were.
Yeah, if you go back to where we were. I don't want to repeat myself. So that's the food insecurity, gradient care in dental care is here. You can see most deprived, obesity, adverse childhood experiences that I was talking about, and some of the health impacts of those adverse childhood experience. You can see the gradients and all this. I hope you'll have the slides because I don't want to take up too much time.
Yeah, we can. Okay.
We'll move forward then.
Great, thank you.
Okay. So the next slide, please. So what can we do about all these really concerning trends? And I do want to keep stating how important advocacy is to call out these issues. These are clear public health issues and health equity issues. There's advocacy that the public health community can make nationally. I think it's really important to continue to make this case because it can very easily be lost. And I've been working at the Institute of Health Equity with Michael Marmot since 2008. And really we have been banging this drum for a very long time, but we find that we need to continue to talk about this at a national level. Very easy to forget these messages with all the other crises and priorities. Local government, of course, child poverty, but again, we can see this very easily slip off the agenda and be deprioritised as the other priorities rise. It needs to be very firmly made. Child poverty is a health issue, it's a healthcare issue. Healthcare system often responds saying that there's nothing that they can do about it, but they're very powerful advocates. I'll come on to what else they can do about it. And of course, communities themselves, we need to enable them to raise their voice and have the sustainable platforms to advocate around the impacts of child poverty and what that means for families and children living in London. We can make the social justice case, and clearly this is a social justice case, absolutely. We can also, and we're often asked, we need to make the cost case, value for money, absolutely. The first thing people talk about when they say they can't do anything about this, there is such a strong cost case around intervening early and supporting better outcomes for children, whether it's reducing demand on services, lifelong impacts, lifelong costs to services and the taxpayer. And the most effective time, of course, to intervene is when children are young and to reduce those trajectories of inequalities. So the cost and efficiency cases are there, and I think we can really highlight these, especially at the moment when the resources are the key barrier to taking action.
And 3 minutes left, Jessica.
Yeah.
Thank you.
We're mitigating interventions and strengthening those partnerships. We move on. Mitigating interventions, we recently produced this report, sorry, next slide, again, commissioned by the GLA about what can be done in London to reduce the the impacts of the cost of living crisis, supporting the cost of essential outgoings, many programmes which you'll find in this report, maximising income, and there's a huge role for employers, which I again think public health can make a very strong case about it, paying the London living wage, making sure that your suppliers also pay the London living wage, and supporting Londoners to have access to all the benefits that they're entitled to, and really strengthening debt financial advice services everywhere where people are, in healthcare settings, in employment, in schools and so on, and people aren't accessing all the benefits that they're entitled to. They're not getting the kind of financial advice that they need, how to manage debt and its very negative health damaging impacts. And I'll whiz through the next slide, please. This is about the uptake of Healthy Start vouchers. In London, you can see enormous low uptake and very different across the boroughs of London. Again, just highlighting the opportunities to support families in the uptake of eligible benefits they're eligible for. And finally, all these different areas, they're all public health, parts of the public health and health equity system, and we need to see public health and the concerns that we all have around child poverty in all of these sectors, and it's the role of public health really to influence, advise, support and hold to account for what they're doing around poverty and reducing the impacts of poverty. Next slide, please. Next slide. Thank you. I won't talk about this now. We are working with Barnardo's and the healthcare system to try and design interventions to support children and young people and those drivers of poor health. It's on our website, and please do contact us. And finally, we have a health equity network. We're trying to build a social movement. Please do join it. Free to join, free to participate. We really look forward to having a strong public health presence as we all work towards building this social movement for health equity. Thank you very much. Sorry for the technical glitches there.
This happens with the best of us, Jessica. Thank you so much for taking us through the data and creating the framework for the discussions that we have and will have today. Now, there are a couple of questions in the chat, Jessica, if you're able to look at them. They ask on specific definitions on child poverty that you would be referring to, as well as adverse child experiences. And I think by managing that in the chat, all of us will be able to benefit from your thoughts on your definitions as well. So colleagues, we say that the values of a society are reflected in how it treats and cares for its children. And I know all of us believe that every child does indeed deserve the best start in life, to be safe, to be treated with care, and to be respected, and to really maximize the opportunities that they can for their lives. So it really gives me great pleasure to welcome our second speaker, who is Professor Ingrid Wolf. Ingrid is the director of the King's Health Partners Women's and Children's Health, and she'll be speaking about actions to mitigate the impacts of poverty through a population health approach to healthcare. So Ingrid, thank you so much for joining us. Welcome, and we have 15 minutes for your presentation.
Thank you. Before I start, can I check that you can hear me? Because I am struggling to hear you. Can you hear me?
I can hear, yes, we can hear you clearly. Thanks.
Well, it's weird for me, so so forgive me if I seem distracted, because I can hear several of myself and a few of you too, so a little bit weird. Thank you very much for your kind invitation. It's such a pleasure to be here amongst all of you, and thank you, Jessica, for that talk, which was both inspiring and depressing in equal measures, I think, and sets the scene really helpfully for the rest of the session. So I'm going to talk about mitigating the impacts of poverty through population health approach to healthcare, and that's because I am both a paediatrician and a public health consultant working in the NHS, which is an increasingly unusual place to be sitting in public health, and I think that's important, and we'll talk a little bit about what can we do still from the NHS perspective on population health regarding poverty. So that's my hope today, in particular, looking at social determinants and nutrition. Okay, so next slide, please. Thank you, Abby. Right, so this will be familiar to you. This is my adaptation of the fabulous Dahlgren Whitehead model, which I've done specifically for teaching in pediatrics and child health. So it's just a little bit focused on children's health with some colors and so on. But the important message, as Jessica's already told us, is that persistent exposure of children to poverty is associated with adverse child outcomes. And I mean that in the very broadest sense, not just ACEs, but every possible adverse childhood outcome that can that I have ever seen measured. And I'll show you a little bit of data, but I'll tell you more about what we're trying to do about it from an NHS perspective in a minute. Next slide, please. Okay, so this is some work in a study that I lead called Oracle, which is about overcoming adverse childhood experiences. It's a bit of a clunky acronym, but that's what it's about. And it's a multi-center study looking at the way that risks cluster and how does that matter for childhood, with a view to then setting up an intervention study to try to deal with these risks, and particularly the way that they cluster, because that's important. In the real world, which we all know, things don't usually happen in isolation, but most of the interventions that we know about that have been studied do look in isolation. So we're trying to get a little bit more sophisticated and look at how things behave in the real world and how they cluster. So what I want you to take away from this graph, it's a study of millennium cohort population, and if you press again, you'll see what I want you to just focus on, please, Abby. If you, yeah, there you go. So what I want you to look at is the way that persistent poverty increases the odds of poor outcomes, and you'll see the outcomes listed on the right. So persistent poverty and poor mental health is a really big problem. Persistent parental mental ill health and persistent poverty. So that's an exposure, the poor mental health, rather than an outcome in that sense. Persistent poverty has increased odds of almost everything other than alcohol experimentation in this study. But if you look at the bottom, you'll see that low poverty and low adversity is the baseline, right? So it really just goes to show what a difference these things can make. And therefore, the flip side of that coin is what a difference it would make if we didn't have those. And in particular, the additive effects, cumulative effects of these clusterings. Next slide, please. And this is just to show you how common these problems are. So what you can see here is that these three exposures, parental mental ill health, parental substance misuse and alcohol misuse, and domestic violence and abuse, increase in prevalence through ages measured in this Millennium Cohort study. So they become really quite common. Next click, please. Now, what you can't see here, but I'm telling you, is that over 40% of children who experience continued exposure to poverty and or parental mental ill health problems, and that's why you see them in the previous slide, that cumulative impact. Next click, please. So poverty is the key reinforcing factor. So the interesting thing about this grant is that we were commissioned to do this by Department of Health and Social Care, who were interested in what was then called, rather horrifyingly, the toxic trio. And those were the three parental exposures that you've seen studied here. And poverty, what we've been able to show, which I'm very pleased about, because I think of the policy relevance here to all of those other risks, is that poverty is the key reinforcing factor in all of it. So these are structural determinants, and they are amenable, as Jessica's reinforced so helpfully. So poverty is associated with double the odds of poor childhood outcomes, is what we found. Next slide, please. Okay, so what I want to show you here, this is a slightly out of date slide, but I think it actually gets worse hereafter. And you will have seen in the news headlines, I'm sure, that infant mortality is starting to flatten out. Instead of continuing to decline, the rate of decline is in fact slowing and flattening. But what I want to show you here is if you separate out the sort of social groupings and the economic groupings, what you can see there is that it is entirely confined, the increase in infant mortality, which is unheard of in my lifetime, the increase in infant mortality, which is a signal of alarm to the state of well-being of the entire country, is actually increasing amongst the poor. Next click, please. So poverty is a matter of life and death, but also politics. Because again, as Jessica has outlined, look what happened in 2010. And I don't need to remind you what happened then, but look what happened to the trajectory of infant mortality amongst the poor and how much that's increasing. For a developed and wealthy nation, that is really disgraceful. And it is also a political choice. Next slide, please. Okay, so let's move on to a little bit about policy and the NHS. So very, very quickly, just to highlight why this is relevant and to put a lens about what's coming next in, cast your minds back to the Health and Social Care Act in 2012, when public health moved quite rightly to the local authorities, but wrongly, in my view, out of the NHS, because I think the NHS is now struggling without public health expertise. So the NHS long-term plan has got a lot of stuff, which is great. About population health, about inequalities, and so on and so forth. But I do think it's tricky for the NHS to translate that into meaningful action without the expertise of this community. So this is a plea to remember our NHS colleagues who are not doing well, in my view, at implementing some of this stuff without specific population health, public health expertise. So look at the core 20+5, reducing healthcare inequalities for children and young people, focused on very clinical areas. How do you actually translate that into meaningful inequality reduction without inadvertently widening inequalities and so on, which is a very public health perspective, which is not sort of at the fingertips of most clinical practitioners and healthcare managers. Next slide, please. Oh, population health management is now all the rage. Used to be called healthcare public health, of course. So what can the NHS do about poverty? So thinking about what my pediatric colleagues look at and are increasingly comfortable with this language, I'm pleased to say, and are starting to think about what they can do as individual clinicians to be more poverty aware. So there are things that you can do as an individual clinician, and there's lots of tools and resources that are being signposted now, for example, by the Royal College of Pediatrics and Child Health. But next click, please. What we can also do in the NHS is healthcare public health, and that is largely about access to care, meaningful improvements in access to care that no longer disproportionately disadvantage children in the way that it would otherwise if it's a very sort of universal access system. We need to proportionately favor the disadvantaged, basically, and that's harder to do than it sounds, particularly for clinicians and managers who are not used to thinking about things like that. So we're talking about the inverse care law, and then there's also other things that we can do. Again, this requires a very different perspective from the NHS. We need to do prevention and early intervention, as well as think about social determinants of health. Again, the NHS is not used to that. We're a reactive service, not a proactive service. A lot of language around that, but not a lot of action yet. Next slide, please. Okay, so this is a very clunky slide that I made a long time ago, forgive me, but this will not be lost on you. This is about Jeffrey Rose's prevention paradox. And this is why I think pediatrics and child health is such a nice way into these subjects, because pediatrics is largely about populations. Most children are mostly healthy most of the time. So what can we do? Click next, please. We can shift this distribution. You see my sophisticated animations. We can shift this distribution by focusing on improving the health of children who are mostly healthy most of the time. And that means general child health problems. That means universal services, health visiting, school nurses, general child health, primary care, and so on. This is the less glamorous end of pediatrics, but it's the more important one. Don't tell my colleagues. Next slide, please. Okay, so what have we been doing in South London? We've come up with something called the Child's Framework, which just stands, it's a very clunky acronym, so I won't bother telling you what it stands for. But what Ingrid, it is on the surface is it's a clinical model of integrated care, but underneath that is the really cool stuff, which is population health tools and methods and a learning health system. So it's a data-driven way to enhance access to care for the disadvantaged children amongst us. We need to be able to know who's disadvantaged, we're able to find them before they get into the NHS or get into secondary care anyway, and then be able to try to open that access door more widely for them. So next click, please. So this is about the healthcare public health stuff that I was telling you about a minute ago. Next slide, please. Okay, so this is the kind of overarching bit of the framework. It's an vertically integrated care model at its sort of outset. So that's primary and secondary care joined up, intrasectoral integration. That's really all the rage in the NHS. But importantly, it's overlaid with horizontal integration, which is about intersectoral cooperation, health, education, and social. That means putting public health a little bit back into the NHS. And then finally, it's longitudinal integration, which is about age-appropriate care. And we can ignore that just for the time being, but it is important. Okay, next, please. Okay, so what does the care model look like? So the way I try and describe it is a kind of an onion ring approach. So there's a core child health team, which is really primary care based, and it has a local child health team. So this is strengthening primary care, bringing GPs and pediatricians and school nurses and children's community nurses and health visitors all into this core local child health team, out of hospitals and into the communities, surrounded by people like myself who are interested in healthcare, public health, lots of data analysts and so on. This is a child population health management team, and we do identification and intelligence and insights, and hopefully intelligence, insights and improvement. Around us is the coordinated wider team, and it's really important to try and join things up. And well, I could get distracted for a long while talking about integrated care systems and how they're not quite integrated yet. We are in danger of reproducing different silos in what we call integrated care, so watch out. So we have a local child health team, and around that we have targeted early intervention. That's the population health bit. So we're using data to find children with unmet needs and scoop them up and try and get them into early intervention care before they get sick. That's the idea, but we're in the early stages still, although we've run a big cluster randomized controlled trial. Next slide, please. Okay, so I don't want you to bother reading all of this. I just want you to this is really to remind me to say that the targeted service is about biopsychosocial care. So it's understanding children's physical health needs, their mental and emotional health needs, and their social needs, hence the poverty thing, and how they all interact together, and like clustering, like I was telling you before, the Oracle study. So we measure all of those needs, and then we try and tailor a care response that meets the diversity of needs, and everybody gets some health promotion and supported self-management, but they also get a tailored care response so that we're looking after the whole child and not just their asthma or their eczema or whatever it is. Next slide, please. Okay, so the first thing that we did, and this is really alarming to me and interesting, and I want to share it with you, we mapped unmet needs. So we looked at the whole of our population. There are 120,000 children who are resident in our area, and we measured how many of them have got the long-term conditions that we started this program with. We looked at about 8,000 of them and did some risk mapping. What did we find? To our horror, we found that 56% of them had at least one uncontrolled physical health condition, by which I mean their asthma, if it's asthma, it's not the only condition, was so poorly controlled that they really crossed the threshold of needing care. Now, these are children who are not invisible, they are known already to the system, but they're in primary care, in the community, with these unmet needs. So that's telling us the system's not working right. Not working well. There's a capacity problem, but there's also a join-up problem. 78% of them had at least one unmet biopsychosocial need, and 16% had all three, biopsychosocial, unmet needs. This is pre-pandemic, by the way, so it'll be worse now. Black children had a 33% increased risk of poor asthma control. I pulled out the kind of things I want to just make you sit up and worry about it. So there's other stuff there, but most of it is worrying. And children from the most socioeconomic disadvantaged quintile had a fifth increased risk of poor asthma control. So that's just telling you more detail of what we've already seen. Next slide, please.
And Ingrid, your time's up, so thank you.
And so, as I said to you, we do this pre-assessment where we ask children with asthma, for example, about their mental health, but also their social concerns. This is pre-pandemic again, and it tells you what is worrying the parents of children with these conditions that we need to look after. How many of them have housing concerns? How many of them have food concerns? You'll see there that the food concern is much lower than Jessica's data. This is a little old now because it's pre-pandemic, but it also gives us information about each individual child so we can tailor a response. Next slide, please. Okay, I'm going to skip over this because I have a feeling I'm running out of time. Yes, okay, right, next slide, please. Okay, so this is just to say, using this mechanism of joining up population health methods with a healthcare approach allows us to do not only early intervention, but to selectively target children who are already disadvantaged. Next slide, please. I think I'm pretty much done. Skip over that one. Sorry, Kevin, I got a little distracted. Right, so just to leave you with some advocacy points about, well, Jessica said all of this really, but we need to remember that this is the thing that's motivated my whole career. If the UK could achieve the same child mortality rates as Sweden, 5 fewer children per day in this country would lose their lives. It's largely poverty, and poverty experienced through the lens of the NHS is what I've talked about today, but we mustn't forget to advocate for change in social and economic policy, because that's really where the big bang is. Okay, and that's it. Next slide is just to say thank you. Thanks ever so much for your time, and sorry, Kevin, to be a bit overrunning.
No, Ingrid, thank you so much. Again, fantastic data. And
Can't
what
hear
I
you,
really,
Kevin. Why can't I hear you?
I think my colleagues can hear us. I'm not sure why you
Oh, dear.
can't. I've been
can't
checking
hear
my
anything.
sound. Yeah,
Hope you heard me.
we can. I'll give you the
Okay.
thumbs up.
Can't I hear you? I can't hear
Great
anything.
presentation.
So annoying. It's probably my computer. I'll mute myself now.
Thank you. So we've started by looking at the macro epidemiological data from Jessica Allen, and then we've been able to dig a little bit deeper in thinking about how do we go from the general to the specific, and what is the role of public health in the NHS, population healthcare, population segmentation, targeting, and development and delivery of evidence-informed programs, and again, another focus on advocacy. We're going to continue to go deeper from the general and the epidemiology, from services, to what it means for leadership and public health leadership. And I'm really pleased then to join our next speaker, who is Dr. Dagmar Zunia. Dagmar, are you on the line today?
Yes, hi, can you hear me?
I can hear you. Can you hear me?
Yes, I can hear you.
Wonderful. So great to see you, Dagmar.
Good to see you, I know.
And thank you for joining us. And, you know, you and I've had the pleasure of, well, training together many years ago and working together for the past decade here in London. So let me just say thank you so much for everything you've done in the city. And, you know, we're so glad you're here to share your experiences as well. And what we wanted to do is have a conversation with you for 15 minutes, just to reflect on why is this agenda important to you in public health? Why are you passionate about children's health? And looking back on your career, what are the things worked? And what do you think we need to do now, given the challenges you've heard from Jessica and Ingrid for public health practice? So I'm going to ask a few questions. We're just going to get into the discussion. But can you just tell us a little bit about yourself, your public health journey, and where you are now?
Yeah, so I don't know whether you remember, but I actually trained and then practiced as pediatrician. So it was nice to listen to Ingrid. And to be honest, I always loved children. And it is their zest of life and their ingenuity that I particularly loved and still love. And already then it was always working with children, not doing it to them. But boy, I did rub at the injustice of the differential life chances. Mm-hmm. And at that time, there wasn't an Ingrid. I felt quite trapped in my role. So I did a stint in rural Africa as well, because, you know, I wasn't 100% sure, am I going to continue? And what happened there, as you well be aware, it is a while ago, but during the rainy season, heartbreaking death through malaria. And what we managed to do, it was a community initiative of the women to do the bed net campaign, so dipping the bed net for every compound in the village. And, you know, the spirit of solidarity amongst these women, after that stint, I applied for the public health scheme. And in a way, Kevin, just continuing, because why is it children? So there is something really fantastic about children and working with children. I said that already. So that's quite a selfish reason. But, you want to have fun in your work. I also always very sneakily thought, actually, people who work with children are normally quite nice. And if you now look around, and I can't see you all, but the amount of leaders for children in the capital, nationally, be it in local authority, in the NHS, I won't list them all because I will forget. They are amazing, amazing people from all walks of life. So I thought, oh yes, if I will work with children, I have nice people to work with. But obviously the most important, and we've heard Jessica, we've heard Ingrid, is Mohammed. The most important public health intervention is giving our kids the best start. So what is there not to do? And now, as we have tragically, in a way, shamefully seen, the need is even further. And I think it didn't just start with the pandemic. It is austerity, the pandemic, and now the cost of living crisis. We have tremendous needs. So if there are any of you out there still in doubt, the kids, they are it. They need you.
The kids are important. Thank you. That's really, really good to give that context. And I had forgotten about your work in Africa. And having also worked in the Caribbean and in different parts of the world, sometimes the intervention impact timeline can be so short by your ability to implement things and see the results. And that sense of positive movement is so rewarding. Now, in your public health career, working as a director of public health, you were in charge of a variety of public health programs, including child health and wellbeing programs. And I wondered, what were some of the opportunities for you, and maybe the frustrations, and then maybe some of the opportunities, things that you're proud of having achieved in that space?
So I think that I haven't got pearls of wisdom that I can sort of scatter. All this, and it was interesting. It was reinforced in a way what we listened earlier. What we need, what I think is the great opportunity for a DPH and for public health, it is mobilizing collective action for health and health equity. Now, it's not new. It's what Atchison said quite eloquently, I think, through the concerted efforts of society. But for me, the question is, how do we do it? Yeah, and when I think about what worked and what doesn't work, I think having the right people around you and getting the right people around, I thought it was really brilliant. Jessica has all the data. Are we always using them out there? I don't think so. If I think about some of the transdisciplinary work, where are the economists? Have we got economists on this call? I don't think so. I'm really delighted that ADPH National has now become a member of the Wellbeing Economy Alliance. That might be something. I've lost a really, really good consultant. He went there. The European Office of WHO now has a new economics office for the same reason, to think, how can we get in collective action mobilized? And just as one example that stuck to me, because for me it's actually small things in terms of leadership. We need others to understand and to advocate for health and health equity. So in one of my previous jobs, when I left, the chief executive very generously, I think, said, why I liked having public health and local authority, and you around the corporate table, all our decisions were a bit better. And I thought, wow, that is the best compliment, because for me it is, health is an investment. It's not just a drain on our coffers. And for me, health is a marker of good governance, of good government, of civic pride. And that gives you a very different sort of angle how you see it. Now, in terms of, I think, concrete examples, we tried locally a classic sort of health and all policies approach. You do need to have the stars aligned, and we had them aligned for a bit, and it started to fly. And I was then thinking, how do I spread the understanding? Because it can't be always me. And I was really thinking about learning from the pandemic, you know, spreading this understanding. And in the pandemic, do you remember, we were always all talking about our numbers. And the pandemic mindset was we wanted to control the outbreak. And I'm now trying and thinking, God, how can we turn it the other way around? What are essential criteria to have a high R, to mix, to exchange, so that we infect lots of others? Because for me, the biggest, in a way, success was when I heard others running with the agenda, not
Exactly.
just me. My director of environment, for example, he became so much of a convert that he would start to say what my directorate is about health and well-being. You know, and I think that's where we you know, get to what we want to do. And poverty is just so fundamental to that.
And I think, you know, what struck me in the conversations so far this morning are a few themes, right? The need for us to be honest and authentic. We have to name the issue of child poverty in order to address it. That as public health practitioners, leveraging wherever we are in our organizations, you've been a consultant, director of public health, to do that advocacy and to use evidence in our programs. And I love what you just said about health in all policies, embedding this across organizations so the issue gets taken up by others. And that really is how we work as systems leaders. Now, to close, Ingrid sort of planted the seed of the ICSs and the promises of the integrated care systems, bringing together the NHS and local government to do more of this holistic programming, life course perspective, thinking of population health. What do you think are some of the opportunities, and what would you like to see as we set up for the next panel discussion, the maximizing opportunities in the ICS? What 2 or 3 things do you think are really critical now?
Okay, Kevin, I will be really naughty and sneak something else in because it is so close to my heart. One thing that I think we haven't quite got is how we deal with stigma and with shame, because the discussion around cost of living, the discussion around poverty, the discussion about obesity, about violence in kids, this is all implied personal failure. Personal failure. Now, that is utterly humiliating and utterly corrosive for what we want, which is collective action. So for me, one of the biggest challenges, what I didn't achieve and I still want to somehow contribute, is that we turn that around and really talk about solidarity. I have spoken to young people who say, I don't want the school meals because, you know, I'm not a loser. We had in the chat again, why are the Healthy Start vouchers not picked up? If you as a mother be treated as, God, she can't even feed her child, it hurts. Shame is horrible. So there is something really wrong in our welfare system. You have to be in the gutter to be worthwhile and eligible. So I'm keen, what are we doing around universal meals, universal income? We need to change that mindset. I had to sneak that in because I really I'm quite passionate about it. And I think going to the ICSs, they're full of really motivated people. Yeah. Don't think, oh my God, you know, the health people don't understand it. I was on that side. I rubbed about the injustices just like you all do, we all do, but I didn't know what to do. So we need to connect up and support. And if I just sneak in at the end, because again, it's close to my heart. So it is, healthy people cannot exist without a healthy planet. So when we think of mobilizing, orchestrating really collective action for health, for equity, for sustainability, do it in that bundle and you get a lot further. The ICS is full of talented and willing people. Look out for them. Together we are stronger than on our own.
We absolutely are. Dagmar, just the sort of shot in the arm we all needed, both your passion and your enthusiasm for this agenda, but connecting agendas as well. And your last point about the triple lock that we should have in public health of health, equity and sustainability is, I think, a wonderful way to sort of bring this section to a close. We're going to now introduce the final panel discussion. And colleagues, please begin to, we're responding to questions in the chat, but if you'd like to put questions in, we're going to have 3 brief speakers now as we continue our journey from the evidence into systems, into leadership, into programs. And we're going to hear from 3 colleagues who are leading different programs across the region to learn about their programs and to reflect on how do they do effective and evidence-informed programs to improve child health outcomes at scale. What is that journey? What is needed? And what are they learning as leaders as well? So we have 3 colleagues who are going to be joining us for this session now. It's a 20-minute discussion, a 20-minute discussion. So we'll be working and asking questions and learning from them. After that, we'll then open up the entire forum for questions from you. We'll look at questions in the chat, as well as those of you who would like to raise your hands. We'll come to you and we'll invite you to speak as well. But all of the presenters will be participating in the panel discussion, so you'll get a chance to engage with Dagmar, with Jessica, as well as with Ingrid. So let's move on to the next session, which is a panel discussion. And I'd like to welcome Dr. Chichi Ekator, who is a GP clinical lead for the AT Beacon project. After Chichi, I'll introduce Jonathan Pauling, who's the chief exec of the Alexandra Rose Charity, and he'll tell you a little bit more about the charity and the work they do. And the third participant in this panel is Emma Pawson, who is the head of health and wellbeing and program director for the free school meal program from the Greater London Authority. I'm so delighted to have all 3 here. So we're going to start with a brief introduction and a little bit of what do you do in your day job and what program are you sharing with us, from Chichi and then Jonathan and then Emma, and then I'll bring all 3 together for the panel discussion. So Chichi, welcome, and over to you. 3 minutes just to tell us about your work and your programs.
Fantastic. So thank you so much, Kevin. It's such a privilege to be here with you all today. So by background, I'm a GP. I also have a pediatric background, which sounds like a common theme today. So I lead the Ascension Trust Beacon project, and we have 6 hubs across Lambeth. And essentially, the AT Beacon project addresses health inequalities through the lens of unmet needs in vulnerable communities in Lambeth, such as food insecurity, access to existing services, nutrition in the home, trust as a barrier and a key determinant of health, but also looking at the disparities in health outcomes for certain communities such as Black, minority and ethnic communities, and also poverty in the home. So we take health promotion services to communities and we launch our hubs in, I suppose, what people would call strange places, such as a barber shop on a busy Streatham High Road, a social supermarket, churches, we're in mosques also, and we're actually in the heart of estates that, you know, historically have had some issues around poverty and also violence and other issues affecting communities. So our interventions include, and I'm sure Jonathan will share a little bit more about, our fruit and vegetable prescription pilot, where we're seeking to look at things from a whole family perspective, seeking to bring resources that actually can help people just to reduce that financial strain in the home, as we know that this cost of living crisis is, you know, escalating. And also looking at parenting, how can we support parents through these really resourceful vouchers, through motivational interviews to engage with existing services, through building health ambassadors, and also signposting to use services appropriately within the system. I come back to trust because for us and in certain communities, trust is such a massive issue. So uniquely, we seek to work with community leaders who are already trusted. We seek to partner with local organisations, with public health, with local businesses, and really just engage communities to live healthier, flourishing lives. So that's a little bit about what I do. I'll pass over to Jonathan.
Thank you so much, Chichi. So exciting. I'm sure we're going to have lots of questions on that. But thank you for those themes of getting out in communities, cultural competence in the development of your interventions,
Absolutely.
but also leveraging your partnerships as well.
Absolutely.
Exactly what we need to be doing.
Yeah.
Jonathan, let's hear from you.
Thanks, Kevin, and thanks, Dr. Chichi. So yes, I work for the Alexandra Rose Charity. I'm the chief executive there, and for the last 10 years, we've been focused on improving access to healthy food for low-income families in London initially, and now across the UK. So in 2014, we developed a concept called the Rose Vouchers for Fruit and Veg project. It's a really simple concept. It's targeted at young families with children under the age of 5 and pregnant women. So it very much mirrors the Healthy Start voucher program from the government. But what we were particularly interested in was to try and incentivize an increased consumption of fresh fruit and veg by both parents and children in early years, because we know that by the time children arrive at school age in reception, around about 20% are already overweight and obese. So something's going wrong in those critical early years around nutrition that's leading to children developing long-term dietary health problems and leading to health inequalities in the long term. So we started in Hackney in 2014, working with local children's centres. So they're already there in the community, engaging families who need support, and those centres are really fantastic at engaging families in their local community. They come into the centre and they try and identify families who are either at risk of food insecurity or diet-related ill health. Our baseline criteria is eligibility for Healthy Start, but we also work with families with no recourse to public funds, and we also know that that threshold is very low, so there are people who are just on the edge of that threshold. So we have a lot of flexibility with the model. They pick up the Rose Vouchers from the Children's Centre and they can take it to local street markets across London to redeem for fresh fruit and veg. And it's also, the key thing about that is it's about choice. It's about giving them the freedom to choose the fruit and veg that they enjoy and that they like, but also that money's going back into the heart of local food economy, so it's supporting local businesses. And I thought there was, you know, really good point from Dagmar about the importance of economics, and that's really one aspect of our work. It's about that holistic circular benefit, both for families and for children's centres and for the local economy. We started with those small pilots in Hackney. We now work across 5 London boroughs: Hackney, Tower Hamlets, Lambeth, Southwark and Hammersmith and Fulham. We're supporting around about 3,000 families every week accessing fresh fruit and veg. And then, and the project's been going really well. We've seen increase from our evaluations. We're seeing that most children arrive on the programme. Only about 7% of the children are eating 5 a day. By the end of 6 months, 64% are now eating 5 a day, which is a huge shift and a huge change. We're seeing similar rates of change in parents. We're seeing changed food behaviours around less snacking on unhealthy food, increased snacking on healthy food, bulking out meals with fruit and veg to make the meals go further, and reduced food insecurity. And so, you know, we knew this model had potential outside of just that, very much that early years focus. And for many years we were looking for the opportunity to pilot an idea around fruit and veg on prescription, and we were looking for the right partners to do that, and we found those in Lambeth with the public health team there, and the AT Beacon project and Dr. Chichi and her colleagues, and also in Tower Hamlets with the Bromley by Bow Centre and the public health team there. And we've been testing those for the last 18 months, and the results are also looking really terrific. So we're now seeing that, you know, vouchers for fruit and veg can help people manage long-term health conditions, can help them manage things like stress and anxiety that leads to exacerbating their health concerns as well. So yeah, we're very excited to see those programs develop and flourish over the coming years.
Jonathan, thank you. Another wonderful example there of the vital role that the voluntary sector and charitable sector can play as an adjunct to our efforts to improve nutrition. And can I just confirm the funding for Alexandra Rose? Are you commissioned by local authorities, or are you fundraising independently of the support from local authorities? Could you just tell us about your funding model and how would you scale, for example, if you were going to imagine a pan-London approach to your program? How would that happen?
Yeah, very good question. It's very much a patchwork of a fund. You know, we're a charity, so we do expect all of our local authority partners to contribute. We have the baseline around 25% of the overall voucher costs, because we know that once they have a financial investment in the program, that they are more likely to get involved, support it, target it to meet their key priorities. And then we fundraise from trusts and foundations and corporates and individuals. It's an ongoing challenge that we face, but we're pretty good at doing that. The scaling is really a big question. I mean, I think essentially, you know, it's really great that public health teams can fund this work, but they have very limited budgets and very limited resources. We'd really like to see that there is an approach from government around this. Fruit and veg on prescription was recommended as one of the actions of the National Food Strategy that the government commissioned, but predominantly ignored, sadly. But they did initially pick up fruit and veg on prescription as a program that they wanted to take forward as part of the Levelling Up white paper in 2022. But of course, during the chaos of last summer, the government sadly dropped that recommendation from their agenda. So we know there's an appetite at central government for this. Rolling it out on a bigger scale, it's a big challenge, because what's unique about our approach is our partnership with local people like Dr. Chichi and AT Beacon, and the local market traders, which really makes it embedded within the community. I imagine when government comes in, they might commission, you know, some big external, you know, a Capita or a Circa or somebody like that to try and deliver it. And it would be in partnership with large supermarkets, which is still good, and I'd still recommend they do it. But I really like the localized approach that we have in those small local embedded partnerships.
Yeah, fantastic. Thank you so much. Emma Paulson, great to see you again, and looking forward to hearing about the Mayor's Healthy School Meal Programme. Over to you.
Thanks, Kevin. I feel a little bit like dry toast after following Dr. Chichi and Jonathan now, but I'll give it a go. So as Kevin introduced me as, I'm Head of Health here at the Greater London Authority, so I'm responsible for delivering both the Mayor's Health Inequalities, but also the manifesto that's in place. Over the last 6 months, I've also become the great pleasure, I should say, of being the Programme Director for rolling out universal free school meals across London, which is the largest scale policy of its kind to be done so quickly in the whole world, which has been fantastic. So what do I do? What does that actually mean? So we in the GLA, thank you for the claps, we work across a whole range of policy cycles. So things that you'd expect to see in that. We gather evidence and insights to make sure that everything that we do is evidence-based. We then think about quite carefully what is within the Mayor's gift, what are the levers that he has. And they are a range of things which cut across things such as leadership. So he provides a lot of leadership to health in the city. He convenes partners. He has a role in champion. He does fund programmes. But then in the teams, we also do direct programme delivery. So that's the scale of things that we do. Everything that we do cannot be done without partners. So we are very heavily reliant on partners to do the delivery with us. We also work very hand in hand. We're quite unique in London that we've got a public health unit. Their role is specifically picking up on the underlying determinants of health, working across what we call the GLA group to try and tackle things that underpin all of our public health interventions that you'd expect to see. I'll give you an example of some of the things that we have been doing. We've got, as I mentioned, the universal free school meal offer. We also do across the GLA holiday hunger. So we're very interested in poverty and food nutrition as well. We've launched a Super Zones work, and the idea of that is to provide direct funding so that we can create healthy urban environments around schools, particularly in areas of greatest deprivation. My team also lead on delivering the Mayor's Health Inequality Strategy, which is the only one of its kind to be statutory in the world. We also do things directly around Healthy School London Awards and water only policy. So really trying to get into giving children the best start in life within setting-based interventions. And then the big thing that we did not recently now, but we had the ad ban, and that's a really good example of where the Mayor, when he does show great leadership, can use the levers that he does have to create a healthy environment for our population and our families. And I'll finish there, Kevin.
Wonderful. Thank you so much, Emma. And I think for those of us who worked in local government and had our own free healthy schools program at the borough level. So I was in Southwark as the Director of Public Health, and that was a big investment and leadership for us in Southwark. And to see that program now being done across London is phenomenal, because it is a buffer for some of the issues related to healthy eating and the challenges for kids in poverty in the city. And as Dagmar says, by universalizing some of these interventions, you take away some of the stigma as well. But the last year must have been just phenomenal in terms of the work that you've had to do to embed this across the city. And I wondered if you had to give one key to success, looking back on landing this program, what really worked? Was it a partnership? What would you say was required to lift and deliver this at scale in such a short period of time?
It's a really interesting question, Kevin, and I don't think I ever realised I would learn so much about school food as I do now. But it is absolutely, it's been the partnership. This could not have been done without schools and boroughs really standing up at pace and with absolute passion. It was just unbelievable, Kevin, that everybody got behind this and did some things, turned it around so quickly. I've never seen a policy, and I've worked in national government at that scale, been done so effectively. We've got every single borough signed up. We only know of 2 schools that aren't delivering this, and that's for very real logistical reasons as well. So in summary, it would definitely be the partnership and just the great will across London to make it work.
Wonderful. Thank you, Emma. So I'm going to ask a question for each of you to reflect on. And then after this, I'm going to invite Ingrid and Jessica and Dagmar back to join the panel. So while they're joining the panel, we'll start again with you, Chichi, if that's okay. For each of you, how, in terms of the issue today of child poverty, can you reflect on the importance of the authenticity, looking at programs and tackling poverty interventions in your work? How do you create that very clear link in bringing poverty to the table, having authentic conversations around it, and then integrating your programs for health and nutrition around it? And the reason I'm asking this question is poverty can seem so amorphous to people and so hard to reach and to engage. And I just wanted to hear from you all and your programs about how is poverty programming changing what you do or influence what you're doing. So Chichi, we'll start with you, and then again we'll go to Jonathan and Emma, and then I'll bring in the other panel members. Chichi.
Thank you, Kevin. That's a fantastic question. I think as a GP, and I've been a doctor for over 20 years, it's really difficult in those 5 to 10 minutes that you have with the patient, that you have with families, to ascertain the core issues that are going through their whole household. One issue that affects a parent ultimately impacts that child, whether it's unemployment, whether it's a mental health crisis, whether it's a relational issue. Ultimately, that child in the home or the children in the home will be impacted by the strain of the finances, the strain on the change in parenting, and also access to the social support around that whole family. So our program is really embedded in getting out of our offices onto the streets, whether that's the streets of Brixton, the streets of Angeltown, whether that's on Streatham High Road, whether that's in the social supermarket, in the barbershop. You can actually feel the pulse of what it means for a person to live with a 0-hour contract, why they can't come for their cervical screening, why they don't engage with, PSA testing, why they can't leave their job to go and look after their health, because literally people are living with the huge burden of the policies that we're making in various sectors of government, various sectors of health. So we go out to people. And I think as a GP, that has been a fundamental shift in the way I practice. It's important to be there where people are, whether that's on a Sunday in their churches, because we know they will ultimately go to their churches, not just to engage with people, not just because of their faith, but because of all the support they're receiving within their local communities, with their local leaders. So as we look at policies, as we look at child poverty, let's frame it in the context of the home, the community, and and what does life actually look like for people? Because actually, if you are in that social supermarket, and I attended the social supermarket with the BBC Radio 4 a few weeks ago, you see the queues of people who have started to queue from 9 a.m. just to be able to purchase fruits and vegetables or just normal basic household items at reduced cost. And they're queuing for an hour, 2 hours.
Okay. Mm-hmm.
So, you know, I think it's understanding what's going on the ground and implementing programs around that as a collective, as a collaborative with community leaders and with public health at the core of it also.
And you know, this is getting to the core of how we improve the public's health. Yeah, we don't do it from behind our desks on a computer. It is about, especially for this public health issue, getting out and understanding our communities. We won't have time now to hear from Jonathan and Emma in detail, but Jonathan, any quick reflections on what you've heard from Chichi? Anything else to add? And then Emma, from you.
Yeah, thanks, Kevin. I mean, I think for, you know, the COVID pandemic and the cost of living crisis have really knocked us sideways, right? So the Mayor of London had the action plan to tackle childhood obesity from the Childhood Obesity Task Force, but then a lot of effort has just had to go into supporting people to manage through these crises, and what I'm worried we lose is a focus on, you know, we're focused very much on food insecurity and making sure people can eat, but we're not focused on making sure that they can eat the right food and getting access to the healthiest type of food. And I think we need to put that emphasis back on that. You know, it's not just about tackling food insecurity, it's making sure it's nutrition insecurity that nutrition insecurity is the real problem that we're facing in the UK today, and we need to make sure that's at the forefront of our thinking.
Fantastic, thank you. And Emma, any brief reflection before I open it up?
Yeah, thanks, Kevin. I'd just add three things, and I agree with everything that's just been said. One is making sure that we have insights. It's personally, I find it heartbreaking to hear some of the stories that we hear about families who are not classed by the government as being in poverty, but they are very clearly in poverty. The second is making sure that we have evidence about what works. So we do a lot of work working with people like the Marmot and our colleagues, looking at all the data and insights to identify and highlight the gap. The gap is getting bigger, which is something that we keep drawing to everyone's attention and everybody keeps talking about. We listen to our partners, the people who are on the ground, knowing what's going on in the communities, tell us what is going on. And then finally, just to make sure that wherever we can, we build it into our policies. As I mentioned at the start, we are lucky to have the health and equality strategy in London. And so everything that we do is about reducing that gap.
Wonderful, thank you. So bring us back to our core competencies in public health: data, evidence into action as what we do. Okay, so at this point we have a final 10 minutes. So we're going to expand the panel a little bit more. At this point, is there anybody who would like to ask a question of the panel? If you could raise your hand, and I'll take perhaps 2 or 3 questions to the panel. So again, I'm inviting colleagues to raise your hands and I'll come to you, and we'll just take all the questions that come up, perhaps 3 or 4 if we have those first. So the first question is from Mike Robinson, and then we'll go to Janet Wilcott. Mike, hi.
Thank you. I've put my question in the chat. So all local authorities invest in a universal public health nursing service, health visitors and school nursing. Obviously, there's the wider determinants, and we've talked about child poverty, but I'm interested in the panel's views. Any suggestions how we work more smartly with our contractors? We can't give them more money to allow them to spend more time with clients, but maybe there are some things that you have ideas how our frontline health visitors and school nurses could use their time without stigmatizing people.
Okay, wonderful, great question. Ingrid and Dagmar, maybe I'll come to you to hear your thoughts on that, those questions, and then let's hear from Janet. Janet Wilcott.
Yes, good morning, everybody. My question is, I work at ground level. I have my own organisation, primarily dealing with children, young people and vulnerable adults who are faced with poverty, and the poverty then impacts education, social care, social services, NHS providing support special educational needs, disabilities, etc. I am often faced with sector departments who don't necessarily understand public health. They don't understand health, neither do they understand the Health and Care Act, recently implemented in 22 last year. And then
your question, please, Janet.
And what I'm asking is, why can we not ask that these professionals adhere to the Health and Care Act?
Okay.
Why is it that we're still having to beg?
Wonderful. Thank you, Janet. A great question. And again, Chichi, I may come to you to lead on that question. Gordon Kay. Let's hear your question.
Hello, I'm Gordon Kay, and I work for Healthwatch Croydon, which gets residents and patient views on all aspects of health, social care. And we work right within communities, just as what was being recently discussed. And the question I had is, it is a little bit around the stigma, but it's also about cultural understanding as well. And what efforts are you thinking of putting there to make sure you can truly engage with communities? Our Director of Public Health in Croydon wrote a very good piece of work on food about 3 years ago, which actually, if no one's seen, I'd recommend. It's on the Croydon Observatory website. And I remember discussing with her and her saying that there's nothing more controversial than food. She said, of all the areas you could ever work into, because it's so linked to culture and beliefs and understandings and perceptions. But what can you do to make sure that you engage with communities on food, that they don't feel they're being preached to?
Great. All right. Thank you. Great question, Gordon. Jonathan, I'm going to ask you to lead on the response to that one. And then Vignesh, if I could ask you to ask your question. And that'll be the final question for today.
My question is just like in practically as in public health, when we're doing like needs assessments and things, when it specifically doesn't focus on child poverty, how do we like help to produce like actionable steps in terms of, for example, introducing the agenda of child poverty and advocating for it when there are particular risk factors for certain things? Yeah, how do we advocate for that in our needs assessments and things when the sole focus isn't specifically on child poverty?
Okay, right. So how do you integrate child poverty in the needs assessments that you're doing? Emma, I may ask you to lead on that with Dagmar as well. I'm sure you'll have opinions. So this is where it gets really interesting. Each of our panel members only has 30 seconds to do a response to their issue. I know these are big issues, and so it's not to diminish them, but it's just to manage the time. So I'm in no particular order of the questions. Jonathan, I wondered if you wanted to start on the question that we gave to you about. Over to you, Jonathan. Yeah.
Sure. I mean, I think it's really important not to preach to people. And I think there is a misnomer that people who live in poverty don't want to eat healthily and don't know how to cook. And I think that's completely false. And actually, there's some great statistics out from the Food Foundation only a few weeks ago that show that the people on low incomes cook more food at home from scratch than people who are wealthier. So I do think the skills and knowledge is out there. For us, it's about basically it's giving you cash to spend on the fruit and veg that you want. So it's not telling you what type of food to buy. It is saying these are just for fruit and veg, but it's your choice. You don't have to join the scheme if you don't want to, right? So we're not telling you to do it. We're just saying, Chi-Chi just says to her patients, would you like some vouchers to buy some extra fruit and veg? And they say yes or no. And if they say yes, they go on the program. They really enjoy it because cost is the key barrier that's stopping people accessing a healthy diet in the UK at the moment.
It most certainly is. And, you know, those principles of starting with the patient, engaging broadly, meeting people where they're at, and doing that in across all of the council, across all of the contact points that you have within GP practice, within the council, are opportunities for us to really take that to scale as well. Emma, I'm going to come to you to reflect on the issue that I gave to you, which is around integrating poverty in the work that you're doing on child nutrition or other health priority areas. How do you do it? Any words of advice?
Yeah, it's a really interesting question. Thank you for raising it. I think the first thing, if you're not talking to your Director of Public Health, then please do. They'd be an absolute vital asset in that. The second thing is making sure that when you look at the data that underpins what's being written, that you are looking at the inequalities gap. Quite often, if you do that, it's not the average. If you look at the average, it hides quite a big need. So making sure you're looking at the top and the bottom of that scale. And then thinking through why is there that such big difference in your borough, in your area? Quite often it's around poverty, and that's a good way of drawing it to people's attention that there shouldn't be that level of gap between the richest and the poorest, in particular, or in different population groups. Dagmar, you may want to add to that, but they were my 3 tips.
Okay. Yeah, and I think, you know, Jessica is here. The Institute of Health Equity, lots and lots of expertise. Reach out. There are others who have done it. Lots of learning.
That's right. Now, Chichi, there's a question on the Health and Care Act, and how do you get health on the agenda of people working in education and health and child and disabilities? So health becomes a common currency. Dagmar spoke about health in all policies that directors of public health can do, but as a clinician, what do you think?
I think, you know, health is a holistic model that we all need to sort of dissect and look at each aspect of that as equally important. So as we've spoken about today, education and how a child starts their life is key to their long-term outlook. So actually services need to begin to speak more together and work more together. So, and that's also important to work with local key leaders, local voluntary organizations. As an umbrella organization at Ascension Trust, we've modeled this over the last 30 years with our key initiatives like Street Pastors, where we seek to be a presence on the street to relieve public health crises, ranging from violence on the street to signposting people to alcohol services, or just keeping people safe on the street. So we need to trickle this down to think about how do we begin to impact child health? How do we begin to impact the health of communities? By speaking to services, speaking together, engaging with your local public health consultants, as we've done in Lambeth, and actually working together and trusting each other that actually, you know, the services that we think should go in this area is what should be delivered. And that trust needs to be equally balanced between local authority and voluntary organizations.
Great, thank you. And this issue of how do we create partnerships that are effective, that transcend organizational boundaries, that are resourced and accountable for real change, I think is the opportunity with the integrated care systems to actually take this further. And so I would say to colleagues, if you don't see health being a common currency, as you said, Chichi, think about engaging with your public health, your primary care leads, your local authority leads, understand the networks and the systems which are there, and continue to advocate for it, because it truly is what we should be doing in this new system that we have. Ingrid, I'm not sure if you're still on the line, and I wondered if you wanted to have any brief closing comments, and then Dagmar, I'll come to you, and then we'll wrap the session up. Ingrid?
Kevin?
Yes, I am.
Oh, sorry, you
Kevin,
are. Sorry.
Oh, yes, I came back. So, well, just very quickly about this tension between universal and targeted, which I think was what you were getting at, Mike, in your question, or what could we do to work more smartly in the universal services, health visiting and school nurses. I mean, that's tricky. So what I have seen over the last decades now is, because of the cuts in funding, they are getting more and more targeted. So health visitors are now focused on safeguarding rather than on health promotion and so on, which I think is hugely unfortunate. I don't frankly think there's much more room for smart working. I think we need to go back to the universal model, and I think it just needs to be adequately funded. So I'm afraid I don't think there is much more smart left in the system. I think we're plenty smart. What we need is to be properly funded.
Properly resourced. Dagmar, any?
Yeah, if I just build on it. One thing is for the individualized intervention, connect the health visitors and school nurses with all the stuff that local authorities do offer. They might be able to sneak it in a MEC approach. little webinar as a commissioner goes a long way. And if it's just the website of the local authority for cost of living crisis, it's amazing how few health visitors know about it. That's simple. But I come back, collective action, it's not personal failure. So I'm really looking at Emma and the universal program evaluation, what we make out of that, to get a political mandate for adequate funding and priorities. That for me is really important, and when you finish this, not to forget it.
Oh, wonderful. Well, colleagues, it's 12 o'clock, so it's time for us to end the forum. Thank you so much for joining us for this event today. We've had a chance to reflect on child poverty, child nutrition, how they intersect. We've looked at it from an evidence perspective, the system perspective, the local perspective, the role of innovation, partnerships, evidence, data, and ways in which we do things differently under some of the most challenging circumstances. Now, there are many takeaways for me today, and from that I'm taking away from this session: the power of partnerships, the power of having that health and well-being as a central core, bringing us together as we work in this very challenged space, the need for continued advocacy, and as Dagmar has said, collective action, and the important role that public health practitioners play. So thank you so much for joining us. I hope you've enjoyed it. Please do complete your evaluation forms. The next forum is going to be in March 2024. And as always, let's keep the conversation going online and in your localities. And thank you for all you're doing for public health. Thanks, everybody. Take care and see you next year.